Hi, I'm Dr. Randy Martin. We're here at the 2023 AATS Mitral Conclave, as you can hear over our shoulder, and I'm thrilled to be joined by Dr. Vinay Badhwar. Good to see you,
Good
my
to see you,
friend.
Randy.
You're a good friend and an excellent surgeon. So, Vinay, I actually read your papers. We wanted to talk about really the risk and outcome of surgery for primary MR, degenerative MR. You have a fabulous paper out. Tell me a little bit about what your findings were.
Well, I mean, as you know, Randy, we've been trying to assess safety of operating on mitral valves. We have multiple other opportunities, transcatheter, surgical, robotic, other ways to do that. And what patients really care about, what providers care about, why our cardiology colleagues care about when making those clinical decisions is how safe is any therapy. And when we're faced with different options, one of the sort of gaps that we've had is that we've been assessing mitral surgery with a risk calculator that was not specific to primary MR.
Right.
It was a catch-all, because when we developed it, and with full disclosure, I was the author on that one, it was really any mitral operation, replacements, repairs of any etiology.
Okay.
So what this analysis did, because the fidelity of the SDS database has evolved, we have much more technical nuances that the operation one does, cords, cuts, but also the etiology in terms of mechanism, degenerative.
So this was specifically for degenerative MR.
So we have 50,000 recently performed operations that were specific by etiology and mechanism, but also by operation. So for example, if someone entered data, say it was primary MR, but then they did decalcification of the leaflets and a patch, that's not primary MR. And we never had that fidelity until now. And so it's a three-part method of really making sure that these are true.
You not only had 50,000 plus, but you had over 2,000 surgeons, and the findings were that it's remarkably safe. Correct?
Yeah, we were surprised as to really how safe it was. Because we talk about low, intermediate, and high risk with all of our trials and all that stuff. And if we go back, how those categories came up, there was no statistical validation anytime for TAVR, for TMVR, or for any surgery, what is defined as low, intermediate, or high. It was done as part of the trial development.
Right.
They estimated as 2, 4, and 8. In this analysis, what was striking was it doesn't matter the age of the patient, the comorbidities, et cetera, though they did have a role in it.
Right.
The overarching of all of the patients in the 90th percentile was just over 1%. So the mitral repair for primary MR, the singular message, is exceedingly safe within all populations, less than 1%, actually 0.5%.
So does volume of surgery make a difference?
So where volume comes in, we found that over 90%, in fact 94 to 96% of all surgeons, of the ones you mentioned, have a repair rate of that's over 90% now. And that's recent, and that's for primary MR. So surgeons are doing it safely and are doing it well. Where the volume comes up, and the safety of execution and repair rates are all volumes, but the conversion rate to replacement, that's where volume really made a difference. So to higher volume
conversion in the OR.
Conversion in the OR.
They went in for a repair, but they end up doing that.
Correct.
That's where the mortality rate goes up a little bit.
That's right. So in other words, to summarize in a different way, is that it's A, very, very safe in everyone's hands. B, the repair rates have gotten over 90% across the board.
Interesting.
So that's a really significant change. That's a testament to the Mitral Conclave and other educational things. We have do so many courses all around the world over the last 20 years. Surgeons have got the message, and they're doing a good job. Now, where experience comes in, though, is the ability to execute a safe repair and now look at durability. But obviously, conversion rates to replacement at the time of OR is a volume-related issue, but not a massive one.
Right.
We're talking 3 to 6% change in the low-volume programs versus much higher.
And you found that it wasn't in patients who had chronic renal disease, that it really didn't make that much a difference. There were certain people, correct? I mean, you would think that increases the patient's risk.
Yes. So when we developed, as part of this, a new risk calculator.
Good.
And that incorporates renal dysfunction, age, multiple other things. Also, the severity of tricuspid regurgitation,
Really?
presence or absence of atrial fibrillation, all those go into that calculator. Now, obviously, when you have someone with primary MR and you've got renal failure, they're 85 years old, yes, their risks are going to be higher. And that's what we would consider the higher risk category. But you know what the high risk threshold was at the 95th percentile?
What?
2.4%.
That's amazing.
The real message, there is really no intermediate risk. It's basically low risk until you hit that type of patient. And then the risks go higher.
So it was a 30-day mortality, which was really your marker, and people would argue, I think the editorial argued that really does not mean quality.
Correct.
So if it's safe, what means quality of outcome?
Well, I mean, a quality metric and quality of safety, if I was a patient or I had a loved one coming to a place, I want to know, is this going to be the only operation I'm ever going to need? And am I going to come out alive without being in trouble? I don't want to have a stroke. I don't want to have bleeding. I don't want to have some complications. I don't want to have an infection. All of those things are what a risk model goes into. So it starts with a 30-day safety.
Right.
It's the safety, then there's the durability.
Okay.
Now, currently, though that's changing, the STS database, what database was used in this particular analysis, is not situated for long-term echocardiographic follow-up. But obviously, what we all consider the litmus test is one-year echo data.
Right. It's durability. Right.
Durability. And readmission rates.
And readmission rates, absolutely.
So all those, that needs to be the next level. And we have to link that to other databases because we don't capture that right now. But I think that's what's going to happen. And actually, we're working on a risk model for TIER that will basically, not to sell it, but we'll be basically talking about.
That's what I was going to ask you, is that, the work was excellent, but that should be applied to TIER.
Absolutely.
Because, it ought to be held under the same scrutiny.
And when we start to look at that, as a referring cardiologist yourself, and most importantly, this is for the general cardiologist practitioner, it's actually for the patients and their families, is that we know that TIER is very safe. And now with recent evidence, it's pretty efficacious. They can get a good initial result. So that's where the equipoise comes in. We do know that there's some hints that, is it going to be durable all this time?
Yeah.
Don't know the question. So that's why there's a randomized NIH trial right now called the primary trial, which is a superiority design.
Okay.
So superiority, not a non-inferiority design.
Right.
That really tries to look at the 1, 3, 5, and even 10-year results of what's the best durable result. And so we're going to find that answer out.
And you said something that in the mitral surgery, it was invasive or minimally invasive. You had robotics included.
Correct, yeah. Currently in the United States, about 14 to 15% of all mitral valve repairs are done robotically. In our center, that's the routine. That's the norm. No one gets a sternotomy unless they need something else or other issues. And even robotically now, we do a lot of things concomitantly.
What's the take-home message from your paper and this safety data for the cardiologist and for the consumer, I guess?
Yeah, I'm glad you said the consumer, because I feel for them, as you do, because there's so many inputs coming from all different area. And whenever we decide on what to do as a physician, regardless of specialty, it should be based and steeped solely on the evidence and large data sets, not, forgive me for saying, industry-sponsored non-inferiority trials that the design itself and the scientific validity of the evidence, raises some questions.
Right.
There's still very good evidence and very important. But, when you're deciding what's best for my patient, it's got to be safe, it's got to be durable. And we do have historical durability in surgery through single institutions. Many institutions have published 25-year durability for mitral repair. So we have that. I think a randomized trial will show that in a lot more head-to-head fashion. But the take-home message from this paper is that for the first time, we've really clearly shown that mitral repair for primary MR is exceedingly safe. It's very successful to have a repair rate across the country. Obviously, experience matters.
Right.
I'm not saying it doesn't. But even in lower volume sites, it's still safe and it's still efficacious. Now, conversion rates and things like that are different in higher volume versus lower volume sites, but it's an exceedingly safe operation. So it's more the patient components. And so when you have that, and they're all low risk patients, we have to be thoughtful of perhaps TEER should be done in the higher risk patient population a little bit more. And since we know the durability of mitral valve repair, that's probably the best option. But truthfully, we really don't have that evidence, and that's why there's a randomized trial.
Super. Well, it's good work and it's needed information. I mean, I think that's really good. So thank you for joining us. Thank you for joining us. Interesting topic. Be informed. Thanks very much.